Hello, everyone. Today we have with us Dr. Abhishek Mangeshikar, a dedicated gynecologist who has devoted his career to women's health. His journey is full of compassion, challenge, and a commitment to make a difference. Hello, Abhishek.
Hi, Rahat.
What inspired you to move into the field of gynecology? I know that you have had a whole family history of grandmother, grandfather, all being gynecologists, your father being a well known, your mother an anesthetist. What made you delve into the same space?
So it was kind of an accidental trajectory into gynecology because I was not the best behaved kid. So I was sent to a naval preparatory academy in the US, which is military school. And I was all set to begin my undergrad studies in finance in Boston. And at the last minute, I figured I don't understand anything about finance. So I said, maybe I want to do medicine. And then I came back to India and went down that path. And that's how I ended up in gynecology, which is a long story. But one would assume being a third generation gynecologist, you would.
It's normally an automatic transition, right?
Yeah. But I was I always wanted to cut my own path. And I did the.
It always is also, no? When you've seen doctors all your life, do I want that too? So I think, yeah, it does have that play in your mind. But I guess your destiny was a gynecologist. And why specializing in minimal invasive surgery?
So from the time I started med school, my initial plan was to either get into plastic surgery or something superficial like that. And I started assisting my father. And I said I enjoyed it. And by the time I came time to choose my postgrad, what I wanted to do, I kind of already knew that I wanted to move towards minimally invasive gynecology, so laparoscopy. That time there were no robotics. And then I moved on to my fellowship and then did a fellowship in gynae oncology and focusing on endometriosis as well. And that's kind of where I knew I wanted to move into. But when I came back to India and started, my initial plan was to do minimally invasive gynae oncology. And that time there was nobody doing real laparoscopy for cancers. So all the big cancer surgeons would tell the patients they needed laparotomy. If you do a laparoscopy, the disease will get left behind. And of course, that's changed now. And what I saw was a lot of endometriosis patients were being misdiagnosed as cancers and they were getting undertreated and misdiagnosed. So I figured that's where I needed to focus my attention.
Yeah, that's my next question. 1 out of 7 women in the world are suffering from endometriosis and without being aware of the same. We just discussed a few of the cases. So, what are the challenges that you faced when you moved into this journey of endometriosis? Understanding that not many, you normally have a mentor you look up to in the thing. You don't have anything.
Yeah, that's a very interesting question. In So the first thing is it's a very humbling disease for a surgeon because even when you're doing cancer surgery, you consider yourself you're at the top of the food chain. But for a cancer surgeon, endometriosis is completely different. So I had to go and relearn everything from the ground up. So one of my most valuable mentors is in France. His name is Professor Horace Roman. So he kind of shaped me and made me who I am. And I am forever indebted to him for that. And I realized that it's very difficult to convince gynecologists, first of all, to separate obstetrics from gynecology. Those days are gone when you had one gynecologist who was treating everything, doing deliveries. And now it's very, very super specialized. And endometriosis is a surgery that is technically more difficult to do than cancer surgery. So you cannot be doing deliveries, you cannot be doing benign gynecology, urogynecology, or even cancer surgery successfully and treating endometriosis. It's a very demanding profession. And then to convince other people of that is very difficult because most gynecologists probably believe they can still treat the disease and they usually end up giving medications to patients to clear up the rest, which doesn't really work. And it was very poignantly put by one of my professors in medical college in India, where they said, I like endometriosis because I can stop when I want to. Now, the whole premise of that is wrong because you can't stop when you want to. You have to stop once you've cleared the disease. And that's where the misdiagnosis and the undertreatments come in for women.
It's like cancer, right? You can't say you've cured cancer till you've actually removed the total cancer out of your body.
Yeah, it's worth in a way because most of the patients are young. They have to live probably 40, 50, 60 years after your surgery. And you cannot do an incomplete surgery and subject them to revolving door surgeries year after year. So you have to do it once and do it properly. But you also have to be very respectful of the organs that are used in reproduction, sexual function, urological function, and bowel function. So you have to be preservative of nerves. In cancer, you can take everything out and
without having those, okay.
restrictions.
Okay. So you've also, in the journey of endometriosis, you've also moved to doing now robotic surgeries. Where do you see that? Is this a new pathway? And I've also heard that the future could be like, as you just shared, you could be having joysticks in one part of the world and you could be operating on the other. So tell me a little bit more about this, and also the aspects that robotic surgeries are not something which people, first of all, understand. And secondly, are they open to it?
So I'm a very good example of the reluctant robotic surgeon.
Okay.
Obviously, so robotics has been around for a while, but most of the people who took to the robot early were not very good surgeons. And Horace himself was a laparoscopic surgeon who later on took up robotics. And he told me, he's like, start doing it. I've been doing it. You'll find a difference in your level. Because even then, laparoscopically, nobody was doing endometriosis surgery with or without the robot at that level.
Okay.
And most of the robotic surgeons looks like everything looked really bloody, like they were giving kickbacks to the blood bank. And it was interesting in a way that because there was no convincing there. You watched the surgery in a conference and you said, okay, I'm cleaner than this laparoscopically, so what's the benefit to the patient? So only when Horace said, he's like, get off your high horse, start doing this, you will find a difference down the line. And I started doing it, so about 3 years ago, and then I said, I'm going to commit to this, and I really started finding a difference. So now I'm very particular about my case selection for robotics, and I moved from doing 100% laparoscopy to I think almost 95% of my volumes are robotic now.
Patients are open to this factor?
Yeah, it's very important that I tell them that, look, I'm one of the few people in the world operating at this level with enough experience in both. Look, usually the robot is knocked down by the laparoscopist saying you can't feel, it's no difference. And they will tell the patients, we have 3D on a laparoscopy, we have 3D on robotics. I mean, that's like a 3D in the movie theater where you wear the glasses and it's projected on a screen. Whereas with the robot, it's 3D like you see in real life. So you have binocular vision. There's a huge difference in that. And it's very important to tell the patient that it's not an autonomous robot. The robot is not making decisions. It's an instrument at the end of the day. Just like the laparoscopy.
Computer.
Exactly. So anybody can do a surgery with the instrument. It truly depends on the surgeon's skill and experience to be able to execute that surgery successfully or not. So the robot will not make the surgeon better. It's just a tool that enables us to be a little safer, a little better visualization, and a little less morbidity and complications.
So safety, mobility, and those are some of the key factors, which is what a robotic surgery would do. Otherwise, it's very similar. You're telling me doing a robotic surgery is it an option, or is it, can I do a laparoscopy or a robotic, or how does it work?
Yeah, it is laparoscopy at the end of the day, which means you're putting a telescope into the abdomen. Obviously, it's an evolution of technology.
Sure.
I say straight stick laparoscopy is going to die in 10 years.
Okay.
I will probably quit it completely in 5 years. The more the costs on the robot come down.
Okay.
Obviously, so laparoscopy is straight sticks, right? So the instruments move like chopsticks.
Yeah.
And the jaws open and close. Whereas the robot, the arms of the instrument articulate. So that means, imagine there's a structure here and I'm trying to operate under that. So with the laparoscopic instrument, I would have to come through the abdomen, lift it up with this hand and operate here. But my blade is still exposed to that vital structure. With the robot, I can flip my camera upside down like that and look at it from here. And I can curve my hand like this so I can carve.
Okay.
It's a wristed instrument. So you can turn 720 degrees. So it makes
See on what you're doing.
Exactly. You see structures very well. You see nerves really well. So your neurological functions outcomes are much better. and you are able to remove disease more aggressively.
Okay, interesting. So we'll go into the factor of what people traditionally feel that menstrual pain is normal. Okay, everybody says when you're growing up that okay, if you've got pain during your periods, it's normal. Just taking a tablet or just put some ice pack or heat pack, etc., and you that. But that is the emergence of an endometriosis, as I understand.
Yeah. So that's very important. We have to communicate that any pain that is causing debilitation or deterioration of quality of life is something that needs attention. If somebody a young girl is missing school, she's missing her social activities, cannot participate in sports, all of that is a kind of a red flag that this may be endometriosis and she should be investigated rather than being gaslit by familial structures or medical structures that it's part of growing up, part of becoming a woman. Many general gynecologists will tell them, once you get married and have a bunch of babies, everything will be fine. There is not one single medical paper that supports that statement. But yes, it's the most widely misrepresented piece of information.
Yeah, that's a
in gynecology.
misconception you live with. Absolutely. And what I also feel at times, um, it is when a woman is young. So a lot of decisions for the women when they're young are taken by the parents, but the parents are very, I think, adverse to the fact because they feel that I don't think it's needed. I think we lived in the times. So how do you clear out this misconception when you meet patients?
I think that's a very interesting point you brought up. Also, I don't know whether I have observational bias to this because usually someone who finds me has kind of either run through the whole thing and researched it, and young patients now are very well versed with the internet, so they kind of do their own research. And interestingly, I actually find the parents of the younger patients that I see very, very supportive.
Okay.
And they're not, very adverse to having a surgery done.
Okay.
Which is great. It's very refreshing. Of course, they are apprehensive. Your child is going to have surgery at the end of the day. But, I think it's very important that I sit them down. I walk them through the process. I do the imaging myself. So I can read the MRI. An MRI is very easy to understand. So I explain it to the patient. I'll be like, look, this is the uterus. This is the rectum. This is the areas around. This is where your disease is. So you have pain here. So it's very important to spend that 1 hour with the patient to understand the locations of the pain, what exacerbates the pain, what it needs.
I think when you actually analyze that and you tell the patient that this is exactly where your pain is, I think there's a comforting factor because a lot of gynecologists, when you go in, they just say, okay, the pain is here, the pain is there. There's no analysis and identifying the clear thing. So then there's a comfort factor. Okay, he knows what he's talking.
Yeah, I suppose so. I think being able to correlate that and show it to them. And if I'm doing an examination and I'm doing an ultrasound and I'm seeing the nodule on the ultrasound and I can push in that area and be like, okay, you have pain here. And she's like, yes. And I say, look, that's the thing that's causing the pain. So for them, it's very validating.
Okay.
Like we were talking about earlier, I had this girl who was being treated in the States and everything on her reporting was coming back as normal. And when I looked at the MRI, I said, you have a nodule in the rectum and it's causing you these symptoms, so and so. And then I saw her in my clinic and I did the exam and I showed her the same nodule. And I said, this is the same pain that you have. It's also would cause pain during intercourse. And she said, yes, that's what it is. And she's like 16 years, no diagnosis.
Wow. And she's living in New York.
Yeah.
It's interesting. Wow. So the topic on menstrual leave, is becoming more. I know I have girls who work with me and we have pain and can't walk, can't do, can't. So Abe, what is your stance on that? Do you think that's important? Or I think when you have that pain, you lead it on to endometriosis. But do you think giving that menstrual leave you've got paternity now, it was earlier maternity leave. Now you have paternity leave. Now there are a lot of youngsters who say, no, we want menstrual leave.
I think it's a good thing. I see there's awareness about abnormal things. So one is, yes, they can take the leave if they need to. I don't know about the social aspects of it in the corporate world. Young women would look at it as a sign of, or it being perceived as a sign of weakness if they take it. So I don't know how much they avail of it. Um,
Interesting. Sign of weakness.
some would, right? They would not take it because they would fear that they may be looked over for promotion if they take too many leaves off.
Okay.
and
From a
stuff.
male point of view.
Yeah,
So
because
it's, yeah, I'm vacation.
some corporates are still a bit of an old boys club, no, I think. And yeah, but I'm glad it's coming about because, some of this pain can be quite debilitating. They're unable to get out of bed, let alone make it to the workplace and
Yeah.
all of that. So I think it's a good step in the right direction. Uh, you also have extreme cases who are in chronic pain. I spoke to someone from Delhi the other day who had to give up a law practice because she was in pain 21 days out of a month. And obviously, if you can't go to work, and yeah, so it can be, of course, menstrual leave and acknowledging that is very important in corporate culture, but it's also a sign that you should get looked into.
Yeah, it needs help. Okay. A lot of gynecological issues are by also being treated by very unconventional methods. You have Ayurvedic, you have herbal remedies, etc., etc. What are your views on that?
I I wouldn't call them unconventional. It's just because I'm in the medical space and I kind of just know Western medicine. It doesn't mean that there's no great science to it. I'm sure Ayurveda has its basis in something as well, as do we use acupuncture in pain management clinics, and it does work. So dry needling is basically acupuncture as well. And so a lot of them have some overlap. And when you see the chronic pain centers, they work in a more holistic approach to incorporate everything. I'm
Okay.
not necessarily going to tell a patient not to try something as long as it's not harming them. And as long as it's not getting them, taking away from the proper treatment, which is
Yeah, because a lot of time you try all these herbal treatments, etc. I feel sometimes you lose out on a lot of time wasted. So, while you're doing these treatments, I think also looking at
Yeah.
a proper treatment is
Yeah.
important, right?
Of course.
So, because it becomes like a trial error, you're focusing so much on all that you don't look at the fact. I think it's fine if it doesn't have any effects as such, but you can't only depend
Yeah.
on that. I guess that's what.
It's not a substitute. I mean, back in the day, they had, a lot of patients were scared of taking chemotherapy, and you had these predatory people and companies that were pushing non-chemotherapy things, and those were having very, very disastrous effects on patients with cancer. Now, endometriosis is kind of going down the same road. Everybody's afraid of having surgery. There's lots of myths and misconceptions about the disease. So, of course, you have other people trying to cash in on that, selling programs and lifestyle changes and certain supplements and whatnot. And it's kind of delaying them from getting their diagnosis and proper treatments, which is, it's fine if you're doing something as an auxiliary treatment uh, to reduce inflammation, for example. There are diets that help with that. I always recommend physiotherapy to help with pelvic floor dysfunction, but nothing is a substitute to actually removing the disease. For even in Western medicine, what medications we have are not to treat endometriosis. They're to stop the period. So the patient is asymptomatic or reduction in symptoms so they don't trouble the doctor. But there is no medicine that has any effect on the disease itself. So
Okay, interesting. But the fact is that we keep on thinking that okay, this is going to help me with, like you said earlier, the diets and all are all for healthy living. So I think you don't have a late dinner, don't drink too much water in the night, don't, all that stuff is healthy living. It's not, I think, a replacement. It's a
Yep.
part of your life. I think it's hygiene.
Yeah,
So I don't think you should look at it as a replacement aspect.
exactly.
That's what I okay. You founded the Indian Center of Endometriosis, I think, more than 4 years ago. Am I right? So, where do you see that going? And do you see that growing? How is it grown? Where is it located?
So we started the Indian Center for Endometriosis, and It's basically still run by me at my center in Laburnum Road. And I have surgical services in hospitals at Breach Candy and Just Oak and Saifi, which is close by. And I do see patients there. I also see patients online. Of course, they are able to teleconsult with me now. They can send me the MRI and I review that and help them get a diagnosis. And I've taken on partners. Also, I work in collaboration with physiotherapists, fertility specialists, nutritionists, and everything, and reproductive medicine. So all of that kind of works together to holistically treat the disease and kind of tailor out a plan for each and every patient. Uh, in terms of growth, I think it's kind of growth organically. Unfortunately, in medicine, it's difficult to scale something because it's very difficult to clone myself. Uh,
But, I think what would be interesting is creating. I think we had a discussion. How do you land up training more people to become a part of it? So, the exposure. See, the biggest challenge with this, people need to know about this. Not many people know about it. It's only when I sit and search is when I get to know about it. How is it that I figure out? So, and I think growing it is also the fact is accessibility. Like you said, you're in Mumbai, and earlier you did tell me that you started in something in Bangalore, but it requires you. So why not setting up it's a training place, where you actually train doctors who move on to your. I think that would be your growth chart as such. You see that normally with every service industry. You train to get in the right skilled people because you know what you want.
so we have fellowships. Um, and we said it's very difficult to convince someone to do only endometriosis. I feel that this is such a demanding disease that you really cannot do anything else. But in India, to convince a gynecologist to firstly give up deliveries and obstetrics is a challenge in itself. And if even if you have a few people who are doing only minimally invasive gynecology, to try and tell them that they need to move away from the bread and butter surgeries, which is the regular gamut of work, which is myomectomies or fibroids and hysterectomies and simple cysts, and focus on a disease that is very demanding and time consuming, and they're going to reduce their surgical volume, is a very uphill challenge. Then also to convince somebody just coming out of training that they have to undergo a fellowship after that for 1 to 2 years is
That's right.
is a very challenge. People look for very quick fixes. They want to learn everything in a month and then go and practice.
I've also seen this challenge talking to a number of doctors, especially in India. They are so comfortable in the kind of work you're doing. The upgradation, the skill set is not there. You don't see that in the youngsters? But internationally, you have people that continuously keep on wanting to upgrade themselves. That's how you see a lot of more movement, a lot more learning, and a lot more discovery.
I think the younger generation is good to some extent. They are realizing that they need to specialize in something. You can't do everything. So you are seeing bifurcations. You're seeing people specializing in minimally invasive surgery. Somebody's doing fertility or just IVF. And you're getting people who are doing some general gynecology as well. So there is some awareness happening, and hopefully there's more and more.
Because see, I think the biggest challenge with India is skill development. I think whether you talk about it from the basic industrial point, from a business point, I think taking it on from the medicinal point also. I think if you have more skill development people, you have more accessibility. I know medicine as a journey is a costly journey. Okay. So I think people, when they get out of it, they want that bread and butter.
Yeah.
But I think if you also have it imbibed, you're dealing with, it's not, endometriosis is not something which is rare. It's there. It can be your bread and butter.
Yeah. I mean, I don't treat any other diseases. And like I said, I'm
You're big.
extremely busy. I have to push appointments for a couple of months to be able to accommodate patients. And it does become a challenge. And obviously, you have to work in multidisciplinary teams. We do very, very complex surgeries. It's not just gynecology, it's multisystemic. So we operate in the chest, we operate in the upper abdomen, and the bowel. We have to remove a kidney, unfortunately, every couple of months for disease that has damaged the kidney. So you have to work in a big hospital. You have to work with the latest equipment, with very good specialists from other professions. So to put that together is a challenge. So I am I'm very willing and happy to train someone.
Okay, taking me to the next question. How do you manage the emotional aspects of your life, dealing with sensitive issues, It does play on, right? It does play on to you, or you are well equipped to handle all this?
For myself or
Yeah, for yourself.
No, of course, it does have its moments where you have to.
You're dealing with a lot of sensitivities, right? You have good ones, you have successful ones, and there are a lot of challenges that also do come in. So how do you deal it emotionally?
I mean, it's part of medicine and surgery, especially. You have to, if you want to, uh, cross the finish line, you have to jump over a couple of hurdles and deal with whatever comes in your way. You have to, have a goldfish memory. If you put your last setback behind you and focus on the task that's ahead of you, and I think that's very important to be able to compartmentalize it. I don't know if it's a good thing or a bad thing, but it's a very
Messy is
necessary skill.
important. I think somewhere down, that thin line you need to
Yeah.
cross because
Yeah.
yeah. And if you do not do that, you have a challenge. So if
Right.
you say that I can also do this and I can also do this,
Yeah.
that comes with the factor. You have a lot of issues in terms of mental wellness
Yeah.
in the kind of industry or profession that you're in. How do you handle your personal life? You have a family, you have children, and I know you work 6 or 7 days a week. So how do you balance that?
Very poorly. But I I enjoy what I do, but I do think my personal relationships end up suffering to some extent. I don't think I'm there for the family as much as I should be. I do consciously try and correct that.
Okay.
And, as someone who is in a space and is very driven, you end up kind of procrastinating and pushing that down the line and saying, when I'm older, I will slow down and I will have more time to spend with the family. And,
Do you do anything to correct the mental wellness part of it? Do you look at moving away? I know a lot of professionals. I dealt with somebody in the legal space. He says, the first week of Jan, I go out and I just do 5 days on my own. I need to reconnect with myself. So is there anything in that manner which you do for yourself?
um, I think my wife is more important in she plans the vacations and
No, I mean yourself. I'm not talking about a family vacation.
so no, nothing for me.
Okay, so you're well equipped to handle everything. I think that's brilliant.
I mean, just mentally, I try and get active, and because I live in the OR all day or in my clinic, and I try to get some activity in, also physical, and get some exercise.
It's more of a me time, a
Yeah.
stimulation, to basically, sometimes because your job is very high pressured, okay, whatever it is, gynecology is not. So, how is it that I create some me time for myself? So, reduce it. A lot of people do meditation, go for trips, go, internally. Look back internally is what I'm talking.
Yeah, I don't think I'm there yet.
Okay.
Huh.
So that's good, actually. I guess you were able to handle the balance. I think that's brilliant. What are the top 3 tips for our women would you advise to maintain optimal gynecological health?
Um, for general health, overall is the logical stuff. You don't really need a doctor to tell you that. Like, eat well, get enough sleep, exercise, get some steps in, and all of that. Specific to gynecology is don't skip the checkups. Go see your doctor at least every year. Pay attention to your body. Pain is usually a good thing. Not that it causes pain, but it's a sign that something is wrong. Um, if you touch a hot pan, your reflex is to take your finger away. Now, obviously, if there's pain, you cannot really take away the cause of the pain, but it's your body's way of telling you something is wrong. So you should look into it rather than stick
So
your.
are there any lifestyle changes you think one should look at? Because if you look at the generation currently, the lifestyle habits, whether it's junk, sleep, the phone, everything together. I know it's more GP driven, but anything driven to gynecology which you feel would affect any lifestyle changes?
So, I mean, for endometriosis, it's not a lifestyle disease. We know it's genetic, and we also know there are epigenetic factors which determine how the disease grows, if it grows, where it grows, how aggressive it is. So a lot of patients say, should I change my lifestyle? I said, unfortunately, it's a hand you've been dealt. It's probably the most common gynecological disease. It's just poorly diagnosed. PCOS, for example, is a lifestyle disease. It does need some amount of correction.
Attention, yeah.
Yeah. So of course, there it is dietary, it is reduction in body fat percentage to reduce the insulin resistance that comes in, so this patient doesn't become diabetic down the line. Yeah, of course that is. So overall health checkups are important.
That's for menstrual health also.
Yeah. And, for younger patients, safe sex practices are very important, getting that awareness in. Now, there's a lot of HPV and I think cervical cancer vaccines are becoming almost part of universal immunization protocols. So a lot of that kind of awareness in health also needs to be talked about with their gynecologists.
So yeah, a lot of young women need to know about their reproductive health and the issues that they're dealing with. I think that openness, especially in a country like India, because it's looked at as a,
taboo.
Yeah. So that openness is very, very important, because I think while I know what's happening with me, I'm a little scared to go and talk.
Yeah.
So that pull feeling, I see that with a lot of people. I see that with a lot of youngsters, and these are educated ones, not necessarily just the, people who do not know about it.
I think even it needs to change on the doctor side as well, because in gynecology, when we're doing residency, the question we ask is, are you married or not, to determine sexual activity? That needs to change in the first place. So we need to ask the patients if they're sexually active or not. And usually they will come in with a parent or, a guardian. And then I'm very in point, and I'd be like, I need to ask them a personal question. So can you step out of the room? And then I ask them, I said, this is, staying between you and me. I need to know, not from a perspective, but also determining how I'm able to examine you. So you can only, for gynecology, you need to do a transvaginal ultrasound, which you can't do with someone who has an intact hymen. So, and then I would send them for an MRI. So also, and to determine whether intercourse is painful for them, because that is one of the big symptoms of endometriosis as well. So for that moment, I asked the guardian to step outside the room, and then I'm saying, okay, now I'm done with the personal questions. You can call them back in.
Okay. All right. So, okay. I think it's fabulous in terms of understanding the whole thing. But I also want to understand from you on a personal bit, who is the one person you admire the most? You did talk about your mentor from France, but anybody else you think you would look up to?
Well, of course, Horace, I have to give him full credit for shaping me into who I am, and where I said, he gives very selflessly. He will, after he mentored me, I would send him cases and he would look at them in the MRI, and he would tell me exactly what I needed to do and counsel the patient on what the outcomes would be. So stuff that I couldn't see yet. And it really, really helped make me who I am. And then, of course, my father, who is a big
fabulous person,
influence in, teaching me to be very, very particular.
I think it's nice to have somebody guiding you. I think, while you take your own decisions, I think having somebody have your back out there, understanding, guiding you. Yeah, he's a fabulous gynecologist. For people who don't know, he's Dr. Prashant Mangeshikar.
Yeah, and I mean, to live in a very, very big shadow and then carve your own niche from there was a challenge, of course. And I didn't mind it. It was a good thing to have him around, and
I think he's very proud of you. Yeah. Very, very proud of you.
And it was a good assistant to have for a very long time. Very experienced pair of eyes to help in the beginning of my career.
More than 40 years.
Oh yeah, he's basically taught everybody who does laparoscopy today.
Yeah, he's like the father of laparoscopy in India. For people who don't know him, can you share one memorable experience that you've had in your journey so far? Something you've, I'm not saying it's just a challenge, but something which you've really enjoyed and you've happy with what came out of it.
So every day is like, because you have, I have very personal interactions with my patients, and I I don't forget them because you have that long. It's not like I'm seeing someone for 5 minutes. I spend a good hour with them, and I follow up with them, and I'm constantly on WhatsApp with a lot of my patients, and I have that good relationship with them. So I learn a lot from them, and they share experiences with me. And one of my oldest patients who I'm still in touch with, and she had a very, very difficult case, and we had to operate twice to get the disease out. And she like sent me an update. She's like, "Oh, I've run a marathon, or I've climbed some mountain or something." And I said, I mean, I don't have the disease, and I've still never done any of those things. I kind of take little joy in those achievements of theirs as well. So
Okay, those milestones that they tend to do.
I live
I think
vicariously.
yeah, a lot of people say you can't do this, can't do this, and when they're able to overcome that, I think that's a good. It's like a success
Yeah.
for them. Okay, so that's your happiness quotient.
Yeah.
Okay, so looking in the near future, where do you see in women's healthcare? Where do you see it going? And what do you recommend?
So I'm from when I started to where we are now, I'm seeing a lot more awareness about endometriosis in a good and a bad way. In a good way that a lot of more people are talking about it. They're more aware about it. They're getting to specialist care rather than going through their generalist gynecologist. You also have a lot of hospitals that are trying to cash in on this. So, the billionaire-owned hospitals are creating endometriosis centers without having trained doctors, and they're very kind of predatory. So you have to be careful of
Do you
those.
see hospitals trying to create training centers for these?
No, they just want to market, right? They don't want to upskill, because there's a lot of time spent in upskilling
Okay.
someone, and they're losing out on that revenue.
Revenue, yeah.
rather
It's
than-
become a business.
Um, it's sad in a way, but hopefully the doctors themselves will kind of say that, okay, I need to learn and I need to upskill when that time comes, which will be good. Also, I think the imaging is improving. So what you would normally get as a pelvic scan would literally only look at the uterus and the ovaries. Now, there are imaging protocols coming in place for endometriosis where you need to look at various other things. You need to look at the ureters, the kidneys. You need to see whether the ovaries are fixed or whether they're mobile, whether the rectum is stuck to the back of the uterus. All those are very, very terrible signs of endometriosis that don't get picked up on normal scans.
Okay. Wow. Interesting. Thank you very much, Abhishek. I think
Thank you
very,
for
very
having me.
insightful conversations, and wishing you all the best.
Well, thank you for having me. I've enjoyed it.